Okay, well, welcome everybody to Journal Club. It's great to see a really good number of people and excited for today's presentation. We have Dr. Andre Seur, who's presenting the various aspects of the management of proteinuria. So Andre, I'll go ahead and I'll turn it over to you.
Well, thank you, JD. First of all, thank you, everyone. Good morning to the people from the West. Good afternoon to the people from the East, right? And good evening for European people and Asia. So first of all, thanks for having me at the American Society. And thanks, JD, for the encouragement of, it's my second presentation in English. So I would say to have a little patience with my accent, and sometimes like I might struggle saying technical veterinary words. But again, thanks for everyone that answered the poll that from Google Forms. That helped a lot, and I think that might bring some discussion during this hour that we have. All right, okay. So the papers that I shared, and there's a lot of information on those. I picked up the most important parts of the management and diagnosing properly glomerular diseases in dogs and cats, and how we might treat those and how we might test before starting treatments, because I don't know worldwide. However, in Brazil, just as a curiosity, there are more than 280 veterinary universities. So imagine the population of veterinary doctors that yearly are in the market. So proteinuria is it's a big step in veterinary nephrology in small animals. And I see sometimes either residents or other colleagues that do have a big struggle on having a proper diagnosis and treating proteinuria nowadays still. So it's really important to keep us updated and and checking every now on a congress or on a meeting, new papers and new discussions to see where are we and where are we going to. So this is after reading a bunch of papers and restudying the major topics. I think proteinuria is the iceberg effect as well. So we think we're getting there, but the urine from those pets do hide a lot of information still. So luckily for those enthusiasts which admire and like proteinuria, we still have a bunch of opportunities for such investigation. So as introduction, I'm going to be very quick. So the urine of healthy dogs and cats do contain only a small amount of albumin and other proteins. However, the type 4 collagen within the basement membrane in the glomerular capillary, sorry about the words, the capillary wall will restrict the filtration of most plasma proteins, primarily on the basis of molecular weight and size. So we know that albumin has approximately 69 kilodaltons, and larger proteins are normally not presented in large quantities in the glomerular filtrate. So because the podocytes, and there is how can I say it? There is like a negatively charged surface which will not let the albumin to restrict its passage. Not only albumin, but other larger molecules and negatively charged proteins. So smaller molecular weighted proteins that do pass, they will almost completely be reabsorbed by the epithelial tubular cells. However, there is a limit a limiting transport maximum on that reabsorption. And that's where the persistent or the presence of a transient inflammation in both sides, either in the glomerulus or either in the tubular cells, then we might have a increased amount of those proteins. So persistent proteinuria as a consequence of proteinuria as a consequence of a glomerular hypertension, hyperfiltration, and changing in the perm selectivity of the glomerular filtration barrier which is proposed to promote an apoptotic response in the tubular cells, altering then the phenotype of these tubular cells and contributing to the development of tubulointerstitial inflammation and fibrosis. Such hard words, but thanks again for the patience. Well, the evidence also suggests an association between renal proteinuria and the progression of chronic kidney disease in both species will have the greater magnitude of proteinuria and the great risk of renal disease progression and mortality. So proteinuria nowadays, it will be a marker for chronic kidney disease if persistent and depending on its concentrations when analyzed. So therefore, an accurate clinical assessment of proteinuria is vital for a successful treatment and prognosis. Again, here in Brazil, sometimes people, colleagues would prescribe some ACE inhibitor and kidney diets without a properly diagnosing. And then if you look in a budget, then you might see how much this is gonna cost and how much the proper exams would cost. Then sometimes you are treating for something that is not actually happening, or it's just a transient proteinuria from other extra renal sources or post-renal. So that's what we're gonna discuss between this afternoon. So therefore, renal biopsy should be considered on those animals with persistent glomerular proteinuria. And renal biopsy here in Brazil, especially, we have just one colleague which he did on a part of his PhD at Ohio State, Dr. Crivelenti. So whenever anyone from Brazil needs help for a kidney biopsy, we look after Dr. Crivelenti to see pricing and how much that's gonna cost. But the biggest struggle here is to convince pet owners regarding renal biopsy. So that's a very limiting factor. I never achieved that success on submitting a renal biopsy myself. However, and furthermore, then if you have a diagnosis for autoimmune or immune-mediated glomerular disease, then immune suppressive agents or anti-inflammatory therapy has been recommended for dogs with this high magnitude of proteinuria and hypoalbuminemia. So then for the first two questions that I asked in the pool, and again, thanks for this 41 people that answered. So as we can see, 39% of this team would collect at a hospital center or a clinical medical center, 24.4 at home, 34 either, and that's 1% selected at the hospital for a culture, and home collection for monitoring. So this is really interesting because we are seeing that new papers and new investigations that that collection at home, we might see that sometimes it's achievable, and again, it would be less stressful if you compare even cortisol levels. So Dr. Shropshire study, she found out that UPC radios from all the methods that comparable in proteinuric dogs receiving medical treatment, Dogs that has a PLN with an UPC higher than 4, there might be a variability between the methods existing because of the higher in-hospital results. So, but whether this finding is clinical relevant, still unknown. Now, Dr. Marinissen's study at baseline, she's collected 71 succeeded with pet owners, and she found out a strong correlation between the UPC and urine collected from free catch and cystocentesis. And her findings empathize that the measurement of proteinuria should be part of geriatric health screening as well, as I would think that everyone would consider if you are investigating any nephrology issues in a patient. And for UPC in dogs, the free catch urine provides a good alternative to cystocentesis. And Dr. Citron and also JT study. So the UPC was not higher when measured in the urine samples collected in the hospital compared to at home samples. However, dogs had higher urinary cortisol creatinine ratio in the hospital, but that ratio was not associated with the UPC. So stress was estimated by that correlation ratio of urinary cortisol and creatinine, and that did not affect the proteinuria levels. And again, they do recommend for further evidence to support and to claim that stress might influence that collection either at home or in the hospital. So I asked another question in your routine. What of these methods do you often utilize for urine collection? And the majority was either for abdominal ultrasound guided cystocentesis and normal micturition, which is the major articles that we just discussed. Okay. So no one does bladder compression. Some people do cystocentesis by palpation, and some still might try a urinary catheter to help out to get that urine. So for prophylaxis in the bladder, then I asked, how often do you perform a urine cultures in your sample prior to run your UPCs? And there is a big discussion either that would be considered if you have to run a urine culture prior to run the UPCs. I would say personally here in Brazil, because you see a lot of budget limiting for all of these exams. I don't know everyone abroad, how is your experience? But here, sometimes you have to choose, not sometimes, maybe all the time if you're not in a teaching hospital. Private practice could be very challenging depending where you work in Brazil. So it's really important to surrogate if they do or if they do not, because the post-renal most influence are urinary tract infections, and sometimes you don't need to invest a lot of money on treating proteinuria that is post-renal. So we see that 58.5% do only in symptomatic lower urinary samples. Another slice is the 26.8, and then there are particular comments that most of them either would culture those based on symptoms or based on proteinuria or symptomatic lower urinary tract, but most of them would run their urine cultures prior diagnosing. And just for curiosity, so the majority was that most of everyone do have automatically perform a antibiogram based on the urine culture. 22 doesn't, and 19.5 only if they requested. And that might be interesting because sometimes you are in a rush or the patient is not doing well, and there are issues of how long these urine cultures might be ready with the results and with the antibiogram ready to treat those patients. So this is like a personally point of view of the duration of those exams that will be ready to the clinician to have on his hands. So I asked again if they treat your asymptomatic urinary tract patients before diagnosing proteinuria. Most of them, 61%, they do treat it asymptomatic. And I asked them how long they would treat, because recently, last year, we had this update with the International Society for Companion Animals with infectious disease guidelines for treating bacterial urinary tract infections in dogs and cats. And what we have to always differentiate if it's a subclinical bacteriuria, which is defined as a presence of the bacteria in the urine as determined by positive bacterial culture from a properly collected urine specimen, right? So the treatment on the guidelines of subclinical bacteria is rarely indicated and it's discouraged. However, in animals where there is unclear signs, so they might recommend a treating between 3 to 5 days of duration of the antimicrobial as recommended for sporadic cystitis could be considered. If there is no clinical response, then antimicrobials should be discontinued as an infection process is unlikely. And compared to the sporadic bacterial cystitis, which is a common condition in dogs and occasionally encountered in cats, so then you have a bacterial infection in the bladder resulting in inflammation and then corresponding to clinical signs. So then the recommended duration on this update for the consensus still is 3 to 5 days. So that was really interesting how the pool responded on those duration of treatment times. We still see that are people treating over 7 days for bladder prophylaxis prior to diagnosing proteinuria, and we have another 1/4 of these 41 people that selected for 3 to 5 days, and the majority 5 to 7 days, always based on urine culture and antibiogram. So it's important that the International Renal Interest Society, IRIS, has recommended substaging dogs and cats with chronic kidney disease on the basis of their UPC. And dogs that have renal proteinuria and a UPC near or higher above of 2 or greater usually would have a glomerular disease, whereas dogs with a UPC lesser than 2 might have either a glomerular or tubulointerstitial disease. So glomerular diseases occur much less commonly in cats. However, they should be suspected when their UPC is greater than 2 or 2. And concurrently, hypoalbuminemia is another added evidence that glomerular disease might be present. So these are the references from the last updated, the modified 2019 IRIS CKD guidelines. And this is kind of a ruler that we might surrogate if there is the presence of glomerular proteinuria or just a function tubular or a post-renal influence according to the UPC levels. And I think this is like the top slide to present and to debate, because it's really important to separate whether if the proteinuria is coming from pre-renal resources such as hemoglobinuria, myoglobinuria, or light chain immunoglobulins from lymphoma or multiple myeloma, whereas the post-renal influence, such as influenced by the urinary tract infections, urolithiasis, transitional cell carcinoma, and vaginitis, all of these post-renal influences, again, might increase your UPC levels, and again, you might be treating to the wrong disease. So it's really important. I love this scheme that really helps the residents, students, and other colleagues that it's not easy to diagnose properly proteinuria. And then if you have actually a renal type of proteinuria, it's important as well to investigate if it's glomerular sourced by or tubular or interstitial. Functional do exist, but evidence-based is still hard to there are not many data about functional proteinuria in small animals, such as extraneous exercises, fever, seizures, or extreme heat or cold. So to differentiate glomerular from tubular, then I'm going to present you guys in further slides some exams that we might see, and we might not be able to differentiate one from another. So when we say who came first when we're trying to assess the proteinuria, has that proteinuria started in the glomerulus and then evaluated to secondarily to the tubular, or it was a familial disease that it has a high magnitude of low light chain molecules of proteins that are not reabsorbed on the proximal tubule, and then you see that on your UPC tests or on a dipstick. Sometimes you have to do a STS page electrophoresis to detect what's going on the tubular cells. So it's important, if we're going to consider the primary sources in the glomerulus, then we have to consider if it's immune-mediated glomerulonephritis, either amyloidosis, or if that patient has a familial, congenital, or hereditary nephritis. So there are some dog and cat breeds which are concerning, and they might be suggested still either for a renal biopsy or having a more elaborated proteinuria testing to see either if it's glomerular or tubular. So for primarily on the tubular proteinuria, then we might see tubular interstitial nephritis and familial and congenital tubulopathies, such as the Basenji breed, that they have Fanconi syndrome. So that would be like a primarily major cause of tubular proteinuria on that specific dog breed. Secondary glomerular causes, then we might have a neoplastic disease, vector-borne disease. That's number one here in Brazil. We do have a lot of vector-borne diseases, and our patients, there is a big prevalence that they do develop CKD because of reinfections and not prevention on those vector-borne diseases. So proteinuria is a big thing down in South America. And there's also secondary glomerular proteinuria due to other drugs or tyrosine kinase inhibitors or tyrosine phosphate, which are more utilized for chemotherapy. And secondary tubular assessment of proteinuria, we might have hypertension, inflammatory diseases, and some high endocrine diseases such as hypothyroidism hyperthyroidism, and hyperadrenocorticism. I might say, I don't know if you guys are hearing, like there's a remodeling house right next to mine, so you might see some wall beating, but I'm sorry about that. I wasn't expecting that during the presentation. So I asked everyone in the pool about laboratory tests for urine protein. So we do have the urine dipstick, the SSA beaming test, which is the sulfosalicylic acid precipitation, microalbuminuria, urine protein to creatinine ratio, and urine STS polyacrylamide gel electrophoresis. And interestingly, the urine dipstick and the biochemistry UPC assays, they are the major exams that everyone has ready available at their clinic or hospital. And impressively, 6 people do have STS-based electrophoresis on their clinic or teaching hospital, which is, I would say, it's very interesting for further research purposes. And I really would like to hear about how routinely would you add this exam, because it's really important for differentiating, especially glomerular to tubular proteinuria, and then that'll be a great discussion as well. If you add that exam on your daily routine proteinuria, or I don't know how much that costs as well. So I don't know if someone would like to say it, or maybe not. Okay, so then we might move forward. Okay, about the urine dipstick. So it's important that we know that it's an in-house and ready available test, and it's inexpensive. However, we must consider the urinary specific gravity, and we have to take attention to false positives and negatives. So the sensitivity and specificity in dogs and cats by Dr. Grower and colleagues in 2004, his results demonstrated that the dipstick test has a 54% sensitivity and a 69% specificity, whereas in cats, the sensitivity is a little bit higher. However, the specificity is lesser with only 31%. And Dr. Syme also saw that on her studies, that the urine dipstick cannot be readily cannot be reliable to identify less severe proteinuria in cats because of these false positives and negatives results. And then, as you can see in the graphic, the relationship between the urine dipstick's results and the more precise quantification of proteinuria by measurement of the UPCs might be, especially because the urine dipsticks do not account for how dilute or concentrate the urine sample might be. So if you only have the urine dipstick and the SSA test, then you might need both exams for a better and accuracy in reliability if that dog has proteinuria or not. You might need to have the proper regions and standards to see how because it's qualitative, it's measured in crosses, so you need the right tubes to see if there is important amount of proteinuria or just traces or just one cross or a negative. And so you should consider the SSA test always associated with the dipstick if you don't have a UPC exam in your routine laboratory. So there was a comment on Dr. Vadent and Elliott paper about the Cauxin in male cats. Cauxin is a member of 1 to 5 mammalian carboxylesterase gene, and it's involved in the production of the cat pheromone precursor. The amount of Cauxin secreted from the proximal straight tubular epithelial cells is related to the sex and age of the cat. So we might see that male cats and intact male cats might have a very intense amount of Cauxin in their urine. So with the excretion would be higher than in mature animals and intact males compared to castrated or females. And Dr. Miyazaki in 2011 reported a simple and innovative method of removing this urinary Cauxin in the assessment of proteinuria in the cat. So the authors have described how they have developed the lens of culinary agglutinin, as they call LCA, which is a lectin tip, and that might remove 90% of the Cauxin, but not significant amounts of other proteins from the urine sample. So that would not influence too much on your protein compounds compared to the Cauxin. And that would facilitate the accurate assessment of abnormal urinary proteins in the cat by conventional dipstick. So that's an interesting study. They do want to do better improvements. There are still 10% of that Cauxin influencing on that urine, and that paper is kind of an interesting thought of, if they're trying to stick with the dipstick, then LCA would be, the lectin tip would be another alternative method. And interestingly, 2 or 3 people, they do detect male cats with UPC higher than 0.6. So that was an interesting, because the majority of the colleagues, they don't see it. All right, so moving forward to microalbuminuria, it's a mildest and often earliest detectable test. So the interpretation and follow-up, it's critical because it's more sensitive, like other tests for proteinuria. MA tests can be affected by lower urinary tract inflammation as well, and therefore there must be a previous assessment of history and urine sediment changes prior for diagnose properly proteinuria. What is interesting is it's that a negative microalbuminuria test will result in a useful finding, because it's not a official proteinuria diagnosis. However, a positive test will be more complex and need to be confirmed with a follow-up test after between 7 to 10 days. So, and when would you indicate for an MA test? When you have equivocal or conflicting results, especially if you have a UPC that it's not consistent along your investigation, or if you have a suspected false positive. For patients with negative proteinuria tests in apparently healthy young dogs and cats that have familial risk for developing proteinuric renal disease, and when you need a more sensitive screening test for a proper diagnosis. Now, talking about the urine protein creatinine radio, it's another quantitative test. So the exam will analyze the total urinary protein and will divide it by the urinary creatinine. So therefore, USG is not necessary. However, Dr. Nabati has, excuse me, do you wanna say something?
Oh, you mean my comments? I was just commenting on microalbuminuria. Does anybody know if the commercial laboratories normalize to a specific gravity of 1010 like the urine dipstick used to do for microalbuminuria?
I'm not sure about the commercial laboratories. When I did albumin to creatinine ratio, sorry, it's Hattie talking, but that was using a completely different homemade ELISA. I was normalizing to urine creatinine.
Right. Yeah, I just have been having a hard time trying to find out what the greater than 1 milligram per deciliter is referring to, because if it's urine that can be any specific gravity, that's not necessarily so helpful.
No.
Okay, moving forward. So if the UPC is higher than 4, then Dr. Nabidi would, on her study, would require, she would recommend that you might need 2 to 5 samples required for actually evaluating the UPC, or consider the three times equivalent samples from consecutive days and pooling. It's important as well because Dr. Rossi and colleagues in 2012, so they found out that UPC significantly increases after 12 hours at room temperature. So it must be already available to you. Collected the urine, you must run your UPC as fast as you can, as soon as possible, or keep it in the fridge for until the 3 days of the collection of the pooling sample size. But do not wait for 1 week. Either keep in the or in the fridge, or then freeze these samples for further studies. So another test would be the STS page, which is the gel electrophoresis. That might help in the differentiation between glomerular or tubular interstitial in origin. So then what we might see, so there is this Brazilian study by Dr. Chapter and colleagues. So they were checking on the urinary proteins molecular way. So they had divided in groups of dogs with iris CKD stage 4, and they could see the expression of urinary albumin was significantly higher in stage 4 than in any other group. And they also investigated the vitamin D binding proteins, retinol binding proteins, and 10 horsefall proteins in a urine sample of 49 dogs. That was a really interesting, and STS page could be a really great alternative. I don't know how much that might cost. What I know here in Brazil, if you have a big amount of patients to send out these exams, they might seem cheaper because the band of the gel you can put more patients, and then you would spend less regions. However, if you have one specific patient, then it could be more costly. So I asked how many recheck exams do you monitor before your final diagnosis of proteinuria? And importantly, and the majority was that they actually do at least 2 exams in a 14-day period. And that is really important to check, because the Dr. Nabidi study also, her results were that the UPC levels, if they are really low levels, you might not see a big difference. However, if you have upstairs UPCs near the 12, then you have a higher variability along the day. So that might be really important to double check, because only one assessment of urine and UPC test does not tell you much, except for what happened approximately in 24 hours of urine production. So it's very important to have at least a recheck, a secondary recheck in a 14-day period. Then for curiosity, I asked what kind of exams do you have at your workplace, and the majority they do have the UPCs, serum chemistry, electrolytes, cholesterol, lesser the thromboelastometry, PAPT and PATT. There was a little bit lesser, almost like the UPC, and interestingly, the CBC machines, they were only 90%. And you see serum chemistry, some people might have more serum chemistry apparels instead of CBCs. Interesting. Okay, so for complementary exams, dogs and cats with glomerular proteinuria are indicated to pursue extended diagnostic testing, and the extent of which might vary depend on the patient characteristics and potential exposure to regional infectious agents, just like here in Brazil. So then it's possible that complete or partial resolution of proteinuria will follow successful treatment of any kind of systemic diseases. So I asked what were the most complementary exams that would you perform in a dog or a cat with a suspected proteinuria. 100% were with a kidney chemistry panel and a systolic blood pressure measurement. And you might see some people looking for kidney biopsies. Other cardio enthusiastic might run an echocardiogram for looking for a secondary disease, underlying disease. Liver chemistry panel was about 73%, and a CBC 87%, and full abdominal ultrasound, that was the third exam most elected. And for those who do struggle with vector-borne diseases, which is 70%, there might be important correlation as well. I found out that this Russian study, which was published last year, and it's Dr. Barbara and her colleagues, they described that Proteinuric is one of the robust proteins that exploitable detection on Proteinuric. So apparently the podocytes you can find the molecular proteinuric Proteinuric from the podocytes, and they found out that podocyte detection in the urine for diagnostic purposes in veterinary medicine. So on that paper, they described the advantages and disadvantages of the immunohistochemical technique currently used for scanning microscopically, chromatography, and immune staining. And her conclusion is that if there is identification of Proteinuric positive cells in the urine, would be a promising diagnostic tool in the detection of early stages of glomerular basement membrane damage in dogs, and cats. That would be interesting. Another, if you are a biomarker nerd and enthusiastic, that would be an interesting study to read. So for renal biopsy, now that we are talking about renal biopsy, I ask how familiar you are, and most of them are familiar. Some are reasonably familiar, and some are not familiar. And that's why we're gonna revise some paths of renal biopsy. And 1/4 have not, of those 41 people, 1/4 of 41 people did not submitted a kidney biopsy sample to analysis, myself included. I only had the privilege to see with JD when I was visiting at UPenn. I got to see how our kidney biopsy is performed, and I was very, very happy and grateful to see that in my life, because we don't get to see that down in Brazil, at least in the big teaching hospitals, because we don't have trained people to perform. And that's why I asked another question. If not, what was the major limitation for for such problem. And the majority will answer about the owner's budget. I can't remember in American dollars how much would be the entire process and costs of submitting a kidney biopsy, but it's expensive, and since we don't have that routine down here, it's kind of a complex to say. But I would think that some lack of owner willingness as well might be. Okay, your dog is sick from the kidneys, so let's stab a needle inside of it. So as a Latino thinker, I would think that most of the pet owners would not let us to have a proper kidney biopsy in the nephrology. So you have to be very convincible in that respect. So talking really quick about renal biopsy, so it should be considered in animals with persistent glomerular range of proteinuria that do not have any contraindications to renal biopsy and do have not responded to standard therapy. So it can be performed percutaneously, either ultrasound guided or by laparoscopy, or blind if you are a professional biopsy stabber, or either could be surgically. And once that you remove, you collect the three fragments of that sample, then you might send to a specific place to run the light microscopy, the transmission electron microscopy, and immunofluorescence test exams, which must be followed by a diagnostic center capable of evaluating these tissues. So must be interpreted by experienced veterinary nephropathologist. So as we call a nephropathologist, right? So there are, of course, some contraindications. So it's debatable if your patient is already at end stage chronic kidney disease, or if it's on stage 3, that could be more harmful and has no value of prognosis. Sometimes the dog or the cat is already very sick and it's very acute and progressive. It's really debatable, or it's too inflamed. I've heard once that sometimes once you collect it and it's too inflamed, the nephropathologist can't see much. So it could be more confusing and it could be a waste of time and money. Uncorrectable coagulopathies, so high coagulation times and low platelet levels also are contraindicated. So if you have a presence of prerenal abscess, multiple or large cysts, extensive pyelonephritis, severe hydronephrosis, history of use of NSAIDs within 5 days, or if the patient is on severe anemia or uncontrolled hematocrit, then you have to double think if it's proper to move on to kidney biopsy. And of course, you need an operator with a bunch of experience, and you must have an animal properly sedated because it's too invasive. So, yes, yes.
I will probably add another one when they have a very high blood pressure, so very severe hypertension.
Oh, true. I totally forgot about it, of course. Thanks. Is that Simona? I can't see the list.
It's me. Hi, Andre.
Thanks for that. Yeah, hypertension. If you don't have your blood pressure control, you're poking the organ that receives 20% of cardiac debit, right? So if you have that magnitude of hypertension happening, of course you might have a hemorrhagic shock. Thanks for that comment. So one of the foundations of a prototype center was developed under the auspices of Wasava RSP by Dr. George Lees at Texas A&M University in the USA. And a second center was established in Europe at a Utrecht University in the Netherlands under the direction of Dr. Astrid van Doggen and Joko van der Lug. I think that the Ohio State with Dr. Cianciolo and the University of Turin in Grugliasco at Tuscany, they might have a center as well that they might do these pathologics evaluations. So
they're the same thing. So the Texas one moved to Ohio, and the one in Italy is basically doing most of the European ones, is my understanding.
Okay, thanks for that update. I was trying to read, but I'm not that updated with the pathology. So thanks for that. Thanks for that. So the Texas A&M moved to Ohio. Thanks for that. And if you are a fan or a big curious to know, there is this book which is available for download. It's free. It's very beautiful, very complete, very didactic. I do recommend it for you to look at the images and trying to understand with the help of these articles as well. It's easy to see what might happen to the glomerulus and to the tubules. It's kind of interesting. I do recommend it. So moving forward to the medical management, it's very important to highlight that the treatment modalities are and must be always be individualized, because we do have a lot of concernings, but not every dog or cat do need all of this treatment. So the treatment must be individualized, and standard therapy forms in the basic foundation for care of dogs and cats with glomerular disease, and it's recommended for use in all affected animals regardless of causation of the disease. Furthermore, it's more important to highlight that treatment modalities, the consensus recommendations are all evidence-based. So this is also important to know and to check, because there is always an update about any specific therapy or treatment modality, or there's another study that disagree or has better results with a larger population. So for medical management, we have the inhibition of the renal angiotensin aldosterone pathway with the prescription of angiotensin converting enzyme inhibitors and angiotensin receptor blocker and mineralocorticoid receptor antagonists. Secondarily, we have antihypertensive therapy with the same drugs with the addition of calcium channel blockers as well, CCB. It's important to remind that PLN dogs and cats are hypercoagulable, so antithrombotic therapy, it's important on those animals. Modified dietary intake with polyunsaturated fatty acids, dietary protein and sodium restriction, and most recently amino acid supplementation. It's very encouraging. Body fluid volume management, it's important to check on diuretics, especially if your dog is in a nephrotic syndrome, and be careful on dosage and when you're going to start prescribing those diuretics, because you can worsen the scenario, the clinical scenario. Attention to fluid overload, especially if we have that old concept that the dog or a cat has a chronic kidney disease and he needs fluid therapy, and so fluid overload, it could be another complication. Serial body weight and bioimpedance spectroscopy would be two assessments for that management of body fluid volume. And lastly, human suppressive therapy with those 6 human suppressive drugs are the most well said in medicine-based evidence in veterinary medicine. So we're going to discuss those further. So the inhibition of RAAS system, of course, will reduce the angiotensin to induced mesangial cell proliferation. It will have a renal vasodilatory effects, reduction then capillary hydrostatic filtration pressure, therefore reducing the proteinuria. But we must never forget that there are adverse effects such as the increase of serum creatinine, hyperkalemia, because you are influencing on the aldosterone levels as well, and hypotension. So it's important to have those ranges always in the control. So for serum creatinine, it's important to between 7 to 10 days to check if there was an increase of 25 to 30% of increase on serum creatinine. Hyperkalemia, so you must keep the range of serum potassium between 6 to 6.5, and do not underscore to have a value under 120 millimeters of mercury above, because then you might have the problem with hypotension. So the first drug selection in the pool, I asked what was the first drug selection for treating proteinuria in dogs, and ACE inhibitors still the majority, but ARBs are getting there, and there were some comments depending on the patient. They might start right as ones with the ARBs. Now for cats, ARBs are the top one choice, and secondary angiotensin converting enzyme inhibitors, the ACE inhibitors, are secondary. So talking about that, so we have this recently article about it's a review article talking about the review of renin angiotensin aldosterone system. I do encourage, and so the magnitude of proteinuria on these dogs. So wait 1 second, I'm computing. Sorry. So talking about Dr. Syme's study, the survival in cats with naturally occurring chronic kidney failure in related severity to proteinuria. Dr. Syme results were that benazepril has been evaluated in cats with CKD, and it's well tolerated and significantly reduces proteinuria. But that study did not document a benefit of benazepril in renal survival. And most importantly, the proteinuria has been shown to predict progression of azotemia, and it's negatively associated with the survival in cats with chronic kidney disease. It's also important to surrogate, because sometimes I've seen and I've heard some colleagues mentioning the association with ACE inhibitors and ARBs, but still there is that combination for RAAS suppression still has been not studied in dogs and cats, and we don't know what might happen, so we might have to be cautious with that. But ACE inhibitors are always a good start, and it's actually a first choice of drug treatment for inhibition. Now the benefits of ARBs. So you have a selectively block of angiotensin receptor 1. So then you might have a renal vasodilatory effects, natriuresis, reduction of capillary hydrostatic pressure, reduction of proteinuria and hypertension in cats, and reduction of cell mesangial proliferation. So we have to give consideration for the same adverse effects and special attention to hypotension, because with the depletion of sodium, you might have a higher drop of systolic blood pressure in cats where was the population previously studied. And interestingly, I asked how frequently do you associate with a secondary drug in dogs and cats? And most of them for dogs, so it got pretty much divided, but 34 was almost between 25 to 50%. So 36 was 50 to 75, and 29, 0 to 25. In cats, so you saw, you can see 48, so you can see more of a well-established, not necessary to increase or associate. However, you see fewer 22% in 25 and 50%, and almost 20% and 0%. So apparently cats do react better under the treatments for proteinuria and hypertension. So we must not forget, I'm sorry for, it's already 2 o'clock, so who needs to leave, I promise you I'm trying to finish that in at the most 10 minutes. So we have to remember that the kidney is a target organ for hypertensive damage, and ACE inhibitors are weak anti-hypertensive agents. So then, because they have a fuel reduction about 10 to 15%. So for treating hypertension on those patients, amlodipine as a CCB would be the most recommended drug for such. And with the new update of the consensus that we have the pre-hypertensive patients, we still need to stay in between an average of systolic blood pressure between 120 and 130. And here is the pool about the needs to increase drug dosage in proteinuric dogs and cats. So then you see that the majority do have to increase. And in dogs, especially, it's more than 50% to 75%. And in cats, it's lesser, 0 than 25%. Monitoring is always important, so we have to monitor for any adverse effects. So UPC, urinalysis, systemic blood pressure, and serum albumin and creatinine and potassium should be monitored at least quarterly in all animals being treated for proteinuric renal disease. However, patients having new drugs introduced or dosage modifications being made for drugs already being administered should be monitored more frequently. We must not forget that changes in urine protein content are most accurately measured by assessing trends in the UPC over time. So because there is a greater day-to-day variation in dogs with a UPC of greater than 4. So consideration should be given to either averaging 2 to 3 serial UPCs or measuring a UPC in a urine that has been pulled from 2 to 3 collections. It's important, very important when you are monitoring because of that fluctuation. For thromboembolism, I asked what's the percentage of prescription? 78% do prescribe either clopidogrel or a low dose of acetyl salicylic acid. And the prevalence is high as 25% in dogs with glomerular disease. It's important to know that the persistent loss of albumin, there is also a concurrent loss of antithrombin 3. And in vitro studies by Dr. Rebelling, they saw also a platelet reactivity. So there is little conclusive evidence based about the prophylaxis of arterial thromboembolism and venous thromboembolism in dogs. So what we must consider is either a low dose of aspirin or a clopidogrel. Heparin would not be a good option because heparin is linked with antithrombin 3, and if you're losing that protein as well, you might have a coagulation disorder if you insist on prophylaxis with that. And there are no safety dosage range for warfarin prescription as a prophylaxis of ATE or VTEs. So there is both studies about Dr. Lennon and Dr. Daniel Gonçalves. That's another Brazilian study about the hypercoagulability. And Dr. Lenny studies indicate that dogs with PLN have thromboelastography values that demonstrate hypercoagulability compared to a control population. However, it might be necessary to predict the point which antithrombotic therapy is indicated. But antithrombin and serum albumin or UPC cannot be used in isolation to predict this result. And Dr. Silvana's study, she evaluated dogs with IRCKD stage 3 and 4, and she found out that the thromboelastometry is more sensitive to detect hypercoagulability in dogs with CKD. However, the thrombin generation test has a potential clinical application by allowing long-term sample storage. So if for further researches, the thrombin generation test has a better potential for such analysis. And this is where I got from the book. So here is a presence of a thrombotic microangiopathy lesion in the glomerulus, and as you can see, so it's very hypercoagulable. The prescription of polyunsaturated fatty acids. So we know that CKD patients, dogs and cats, do exhibit alterations in the vasoactive urinary eicosanoid excretion. So dogs with glomerular disease should be fed with a diet with between a ratio of 5 to 1 in omega-6 and 3 respectively. If you want to convert that dosage for a better assessment with pet owners, here is the recommended dosage. And it's important to know that the PUFA within a diet or stored oil as a capsule, it may be oxidized. So you have to keep your pet food or your oils always looking on the expiration and protected from sunlight and oxygen. And here in the pool, 31% do encourage pet owners to give to their pets with PUFA, and 100% it's about 14.6. And thirdly, 24.4 between the 50 to 75%. Talking about diet restriction, it's important to remind that renal diet is modified in protein content that might reduce intraglomerular capillary pressure. It will develop a better magnitude of the proteinuria and generate and would be lesser generation of uremic toxins. However, this reduction in proteinuria apparently is small based on evidence. So dogs with PLN must have they do also have altered amino acid status, and there are 2 studies that I referenced, Dr. Zatelli and Dr. Parker, and both of them they found out in a prospective observational study that PLN dogs, they do have lower concentrations of leucine, threonine, histidine, glycine, proline, and many others, and that supplementation they did improve in body weight and serum albumin levels, but did not but it might have a prevented decrease in proteinuria and urea concentration. Talking about sodium restriction, it's important that nephrotic syndrome patients are salt sensitive. So sodium restrictions and sodium restriction will also enhances the antihypertensive efficacy. Lastly, for immunosuppression, then it's important to know that nearly of the 60% of the dogs with glomerular proteinuria will have either immune complexes mediated glomerulonephritis or amyloidosis, and both of which may represent an error on excessive immune or inflammatory response to all infectious, neoplastic, or inflammation conditioning. Therefore, the empirical administration of immunosuppressive or anti-inflammatory therapy has been recommended for dogs that have no non-contraindications for specific drugs being considered and have severe, persistent, or progressive glomerular disease in which there is renal biopsy supported evidence or immune-mediated pathogenesis. So it's important that we might look after for the evidence of electron density positives, either in positive immune fluorescence or in lesser evidence in light microscopy by Mason's 3-chrome or Jones methionine silver. So I asked in the pool if you ever had to prescribe, and the majority of 90% said yes. And if yes, if they will be based on a pathology with renal biopsies derived, and 89% answered no. So renal biopsy is still very limiting, apparently, to the most of people that answered. And then I said, on the following question, I asked, if no, which exams would help you to suspect for glomerular disease? Google did not help me out on that, so I was checking all of the answers and I put on that table. And UPC and the lack of response of the treatment were the most two commonly responded. So 15 of those 34, sorry, that answered said the UPC, hypoalbuminemia, vector-borne testing, history, chemistry panel, abdominal ultrasound, rule out pre and post renal causes, and STS stage were the most repetitive answers. And there are others. There are other exams or clinical findings that they would suspect for glomerular disease. So here are the four investigations types. So transmission electron micrograph, immune fluorescence, the Jones methionine silver strain, and the Mason's trichrome stained. And in the cat world, things got a little updated because we used to say that the primarily histopathologic lesion is tubular interstitial nephritis, and the magnitude of proteinuria is typically low, with reported to medium urine protein to creatinine ratios in iris stage 2, 3, and 4. But most recently, Dr. Rossi and colleagues, they found out in an investigation of 68 Klein-Down cats that 54 presented immune complexes glomerulonephritis and 45% presented non-immune complexes glomerulonephritis. Interestingly, from the immune complexes population, 48 presented membranous glomerulonephropathy as MGN. 37 present membrano proliferative glomerulonephritis as MPGN, and 13% presented mesangial-proliferative glomerulonephritis. And furthermore, cats were more frequently, this population, the cats were more frequently tested positive for FIV or FELV induced, infected, sorry. Younger, and they were younger and had higher UPC ratios than the non-immune complexes. And on the other side, for the non-immune immune complexes glomerulonephritis, 29% presented a focal and segmental glomerulosclerosis, 19% with a global and multifocal mesangiosclerosis, and 6.5 with glomerular atrophy, 6.5 with renal dysplasia, and 3.1 with amyloidosis. So that's a very interesting for biopsy evidence-based in a larger population of cats in Europe. So for the drugs, the immunosuppressive strategy selected to manage dogs with documented glomerular disease in apparent immune-mediated pathogenesis should be selected on the basis of the severity of the disease and its rate of progression. So if you have a rapid and progressive disease, so you might double check if there's no evidence of chronic disease or seroalbumin is lower than 2. The patient is not in nephrotic syndrome or then in a rapidly and progressive azotemia, then it's advocated to use a single drug or a combination therapy at least for 8 weeks if no adverse effects. And the most common drugs are mycophenolate, associated or not with prednisolone, or cyclophosphamide, associated or not with prednisolone. However, if you have an active but slowly or more delayed onset, then you might choose a set of either mycophenolate or cyclophosphamide with or not with glucocorticoids, chlorambucil with or not associated with azathioprine in alternate days, or cyclosporin. So then you at least might treat those for at least 8 weeks to 12 weeks if no adverse effects. And on the pool, the best combination was glucocorticoids with mycophenolate. Interestingly, mycophenolate got the greatest answer. And the exclusion criteria, it's important if the patient has a non-immune mediated familial nephropathy, and then you might check on many sources of references, the specific breed and the disease description that it might have, the age at presentation, if there is inheritance of mutation, and if it's going to be progressive to renal failure. Speaking of amyloidosis, may be more likely, although the evidence suggesting that reactive amyloidosis in dogs is associated with a dysregulated immune response, immunosuppressive therapy in dogs is either or no benefit or may contribute to more rapid progression of the disease. And despite glomerular amyloidosis in dogs can be associated in a very high UPC values, there's too much overlap in this between dogs with amyloidosis and dogs with other glomerulopathies that reliably use UPC value to predict histopathologic diagnosis. So it's important that we cannot make these decisions based on the UPC, and always check the predisposed breeds. As an example, the Sharpei with a cyclic fever and joint infusion, or with amyloid deposits in other organs such as the liver. For monitoring, systemic and clinical laboratory monitoring is essential to optimize the therapeutic management of dogs with the glomerular disease. So the regular follow-up should include clinical signs as adverse drug effects, GI signs, dietary intake, body weight, body condition score, assessment of peripheral or pulmonary edema, ascites, pleural effusion, systolic blood pressure, and quality of life. Follow-up laboratory assessment should include also a CBC, serum chemistry such as serum albumin, urea nitrogen, electrolytes, serum creatinine, hepatic enzymes, and cholesterol. Also the UPC and the assessment of other underlying disease. And initial assessment should be performed no later than 1 to 2 weeks after initiation of the treatment, and every 2 weeks thereafter for the first 4 to 6 weeks of treatment. Thereafter, the assessments are recommended at least every 4 weeks for the next 3 months, and then quarterly intervals until the resolution of the disease. And here again, Google did not help me out, but most of them did respond weekly at start, and then monthly or every 3 to 4 weeks. I also asked in the routine, how was the rate of success for immune suppressive therapy? And sadly, 48.8 still are under the between the 25 to 50%. However, thinking on the optimistic side, we are having at least 50% of treating resolution. It's important that in patients with acute presentation, renal function and markers of azotemia such as serum creatinine and urea nitrogen, they may return to references ranges spontaneously or in response to standard therapy or immunosuppressive therapy or both. In contrast, the dogs with long-standing persistent proteinuria and chronic kidney disease, or in dogs with acute presentations, the glomerular damage may not repair and may remain abnormal with progress or resolve incompletely as a partial response. For partial responders, some degrees of sustained azotemia may be expected, and maintenance of stable renal function can be regarded as a therapeutic goal. Also, the response to the treatment should be assessed by changes in kidney function and measured by changes in serum creatinine in normally hydrated animals, that's important. And although there's more increases in serum albumin concentration, that may reflect a response to the treatment, and the therapeutic goal is to achieve a serum albumin concentration either higher than 2.5 or partially if you have an increase of at least 50% from the pre-treatment or a sustained increase between a target level of 2 or 2.5 grams per deciliter. You might see also body weight stabilization and the resolution of the edema if that patient is trending to be in a nephrotic syndrome. It's important that the immunosuppressive treatment should be discontinued when clinical intolerance or life-threatening, such as GI signs or pancreatitis or systemic bacterial or fungal infection, or if they develop hepatotoxicity by azathiotripine, or they have a bone marrow suppression with leukopenia, with neutropenia. Sorry, if it's present, then it should be discontinued or modified transiently until the leukopenia is improved. Treatment should be discontinued or adjusted if any other adverse effects are reported by the owner that can be attributed to the immunosuppressive therapy. And 3 to 4 months are required before to declare no response. I guess this was my last slide. Thanks again for the opportunity. I'm really sorry for that long delay. My English and the speaking when you're trying to speak fast is complicated, but thanks again, and I hope that brought some. Oh, sorry. Where is it here? Okay. Thanks, JD.
That was great.
Again.
Thanks so much. That was a great
I'm really
presentation.
sorry taking that long. I don't know if you guys understood with my accent, but I tried my best because there is a lot of technical English words that I struggle and I'm not used to say it. So I don't know if anyone has any further comments. If you ever come to Brazil, if you are in the São Paulo state, you are more welcome to visit our teaching hospital. And my email is there. And thank you everyone for being faithful in staying 25 minutes extra with me and with us here. Thanks, JD.
No problem, Andre. Thank you so much. That was a great presentation. Really appreciate that. I'll go ahead and stop the recording.